Prof.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi taala wabarakatuh, and a very good morning to everyone. Today is our pleasure, the Department of Psychiatry, to be bringing to you a case presentation and discussion. Today we will be focusing on dopamine in the brain. About finding the Goldilocks balance for a patient with Parkinson's disease and psychosis. But before we start, I would like to introduce myself and the speakers. So I am Professor Marhani Midin, a senior member of Department of Psychiatry. I'm the chairperson today. And with us, we have three speakers. I'll just introduce the speakers according to their order in presentation. So the first speaker is Dr. Setu Karasi Anak Perempuan Narayanan. Dr. Setu is our trainee in the department, and she's going to be a psychiatrist soon in a few years' time. And she's been involved in managing the patient. And our second presenter is Associate Professor Dr. Shahrul Azmin Muhammad Rani. Thank you, Prof. Shahrul, for joining us today. Between us, the Department of Psychiatry and Department and neurology, I always feel that we have special connection, and that's not surprising because we are managing that group of patients. You all managing the physical part of the brain, patients with physical conditions of the brain, and we psychiatry are managing the patients with the mental conditions of the brain. So I really appreciate the working together between us, all this while and in the future, inshallah. And for today's discussion, your input is definitely needed. Thank you for joining us. And our third presenter is Dr. Hajar Muhammad Salih Sahimi. Dr. Hajar is a psychiatrist in our Department of Psychiatry. She has a bright future in psychiatry. Yeah, and today is her very first presentation in CPC. Yeah? So, right, without further ado, I would like to invite Dr. Setu to present the case. Go ahead, Dr. Setu.
Thank you, Prof. Mahani, for the kind introduction. Good morning, dear professors, specialists, fellow colleagues.
Dr. Setu, can you make your slide? I can see your notes in your slides. Can you change it?
I thought, let me see. Just one second.
Go to share screen again, and then basic, you click advanced.
Oh, okay.
No. So this is the Zoom. So your issue is the Zoom software, Zoom capture, not the PowerPoint capture. Yeah. Okay. Share. Click share again, and then when you share screen, you click on the advanced. Otherwise, you'll give the game away. You see all the notes. Yeah, and then you adjust that box. I think you see a box, a border. Yeah, so that it captures just the slide that you want to show to the audience.
Thank you, Prosmin, for the technical advice too. Are you okay, Dr. Setu? I cannot hear your voice now.
Yes, I am. Okay. Oh, sekarang. Okay.
So then you right click.
So I have to make it bigger, right?
Wait.
Oh, I did.
You right click dulu. No, right click and yes, that one. Okay, then you. Okay.
Oh, okay. Wow.
Yeah.
Okay. Okay. Thank you, Dr. Hajar, Dr. Prof. Oh, is that okay? Okay, nampak sekarang? Is it better now?
Yes.
All right. Okay. So again, thank you so much, Prof. And good morning to everyone who is attending this CPE, for taking time and joining the seminar today. So without further ado, I'll start my presentation. So as Prof mentioned, today we'll be talking about dopamine in the brain. So our title will be Finding the Goldilocks Balance for a Patient with Parkinson's disease and psychosis. So okay, so we have Mr. Z here. He's a 61-year-old Malay gentleman. He's married with 4 children, and he's a retired engineer. So Mr. Z, who has been diagnosed with Parkinson's disease, he presented to us, to the psychiatry team, with psychotic symptoms, which were the persecutory delusion and delusion of control, and also visual hallucination. He presented to us in March 2022. So when I was given the task to go through this patient's file and understand his case, I realized that this is a rather complex case with multiple issues to be tackled. So I'll just give a brief introduction of this patient, and further details I will explain in the following slides. So in June 2018, he was first diagnosed with idiopathic Parkinson's disease and he was started on dopaminergic medication. Subsequently, in January 2019, we noticed that patients started being very particular and quite controlling about the frequency and the timing of the medications, which he adjusted according to the symptoms that he experienced. So in following that, in September 2019, a referral was made to the psychiatry team. At that point, he presented with anxiety and depressive symptoms. And in October 21, he developed psychotic symptoms. So the psychotic symptoms will be the main topic of interest today. All right. So I'll proceed with the HOPI. So this patient, he had in total 3 admissions to the psychiatry ward consecutively. So we would consider this whole, all these 3 admissions as one episode. So he was admitted to the psychiatry ward for unmanageable behavior. He was staying in a nursing home at that time. He presented with a few psychopathologies. One was we noticed that he has this hypersexuality where he was behaving with sexually disinhibited towards the female staff in the ward, such as asking for affection very openly, and he watched pornographic materials in front of others. And he had delusion, which was persecutory in nature mainly. He believed that he was the staff are going to harm him in some sort. And he had visual hallucination where he reported that he was seeing kids in the nursing home. Apart from that, he had increased oral intake as well as rapid and exaggerated changes in the mood. So as this behavior continued, it worsened, and which led to aggressiveness towards the nursing staff. So during our psychiatry assessment in the ward, he did not have any depressive or anxiety symptoms at this point. He had earlier in September 2019, but in March 2022, depressive and anxiety symptoms resolved. And apart from that, he had prominent motor symptoms, which he reported to have freezing episodes, which he explained as muscle being pulled, feeling unstable, and there was drooling of saliva as well. So whenever he sensed these freezing episodes, he insisted on his Stalevo. He was on Stalevo at that point of time. So and so here we can see the initial impression was dopamine dysregulation syndrome. So you can see a temporal relationship between the increment of the dopaminergic medication as well as with the non-motor symptoms here. So his medications were altered and simplified. So his Madopa, which was his previous medication while he was under follow-up, was switched to Sertraline, and Stalevo was reduced from 6 times daily to 5 times. And even prior to the admission, the family actually brought this patient to a private psychiatrist when he had this disturbing behavior. He was started on antipsychotic, which is quetiapine, by a private psychiatrist. So I need to highlight here that after his admission, when the dopaminergic drugs were altered, reduced, we noted that he had marked improvement in his psychotic symptoms. So hence his antipsychotic was stopped while he was in the ward. And during this admission, we also ruled out frontotemporal dementia as his MMSE as well as MoCA were normal, and CT brain reporting actually just mainly age-related cerebral atrophy. Then he had a second admission, which was in May 2022. Here we noticed that his psychotic symptom was again quite florid, despite he was on a low dose of dopaminergic medication. So he's actually here, if you see, the persecutory delusion was more prominent, where he believed that even the wife is conspiring with the staff to harm him, and he had some delusion of infidelity as well, believed the wife had extramarital affair. And he had delusion of control, where he believed the staff can manipulate his mind. And he also had some sensory deception, illusions, where he often misinterpreted certain painting or images to something else. And the freezing episode did continue. He still had those freezing episodes. So his behavior was quite unmanageable in the nursing home, where on top of these symptoms, he was also refusing to take his medication and often became agitated. Hence, required another admission. So in ward, we noticed that he somewhat had very demanding behavior, which was quite challenging for us and also for the staff who was attending to him. He expected the staff nurses to comply promptly to his requests and questions. At this point, the diagnosis was revised to Parkinson's disease with psychosis. So here it was quite tricky as the management required a careful balance between the dopaminergic medication and also the antipsychotic so that we don't worsen either one of the symptoms. So here, quetiapine was restarted and was optimized. Stalevo was reduced from 5 times daily to 4 times daily, and selagiline was discontinued here. So then that led to, after that, the following month, it led to the third admission because this psychotic symptom persisted and he was aggressive. At this point, we can see he had very poor impulse control, and which led to the aggression. Other than that, he being impulsive, we can regard it as he had this engagement in activities which can cause negative, adverse consequences, such as asking for sexual favors. So here we admitted him to further stabilize his psychotic symptoms by optimizing his antipsychotic. All right. So since this is, we consider this as a one whole episode, so we had some challenges in this, in the management. So other than the main medical symptoms, we had to was quite challenged with other psychosocial factors as well, such as marital disharmony that he was facing. I will explain this in detail in my following slides. His marital disharmony, which was quite chronic, and another thing is he has been reported to have narcissistic traits in his personality, in his premorbid personality. So his insensitive behavior and the traits itself caused a lot of interpersonal relationship issues with his wife, family, and etc. On top of it, he had a financial constraint. This was quite stressful for him because he had to pay off the debts and he was unemployed at that time. So all this contributed to his family having caretaker distress and experiencing burnout, which subsequently led to poor family support. So I'll proceed further to past psychiatric history, which is quite straightforward actually here. His first contact to the psychiatric team was in September 2019, where he was diagnosed with anxiety disorder with depression. He was started on vortioxetine. It's an antidepressant at that time. And then towards the end of the year, he was referred to the community psychiatry team as he had some difficulty coming to the clinic due to the difficulty in mobilizing secondary to the Parkinson's disease itself. What we notice is in October 21, he developed the psychotic symptoms. Hence, he was started on quetiapine. And following that, he had the 3 admissions to our ward. So past medical history, he has underlying hypertension and dyslipidemia, which is where he follows up under clinic Jabatan. He has been diagnosed with cervical spondylosis, but at this point of time, it is not a major concern here. And an idiopathic Parkinson's disease since June 2018. So I will show a timeline here. The timeline looks a bit compact and there's a lot of information here. I'll summarize it. So he was diagnosed with Parkinson's disease in June 2018 and he was started on the dopaminergic medication. And in January 2019, he somewhat had controlling behavior on his medication, which led to increase. He started using the dopaminergic medication according to the symptoms. If the more freezing episodes or stiffness he experienced, the more medication that he took. So along the course of his illness, the severity of the motor symptoms either remained the same or it worsened, which so hence the dopaminergic medications were either optimized, or there was one time that the medication had to be switched to another type of anti-Parkinson's medication. So somewhere in September 2019, he developed anxiety and depression, which warranted a referral to the psychiatry team. So the psychiatrist's symptoms, I have put it in blue color. So then we can see here that initially his MADOPA was 5 times, then it was, from a lower dose, it was increased to more frequencies. Then it was cross-tapered with Stalevo, which was then, the Stalevo was increased up to 6 times per day. Then we notice there's a temporal relationship here with the increment of the dopaminergic medication and the non-motor symptoms. So here, actually dopamine dysregulation syndrome was actually suspected at this point. And along the way, in October 21, he developed the non-motor symptoms, which is the psychotic symptoms and hypersexuality. Hence, the quetiapine was started, and subsequently is the admissions that I presented in my history of presenting illness. So I will go to the family history next. So his son has autism. Apart from that, there's no other mental health issues in the family. There's no history of Parkinsonism in the family. So Mr. Z has a degree in chemical engineering, and he has completed his MBA. And regarding the work history, the longest that he has worked is as an executive officer for about 15 years. Then after he resigned because the company was minimizing the number of employees, he resigned. Then if you notice that he cannot really sustain a job for a long period, partly probably because of his personality traits, where he thought he was not given certain privileges that he felt he's entitled, and often he felt not appreciated in the workplace. So so that's why he had to change jobs multiple times. However, in 2018, he actually stopped working completely when the diagnosis of Parkinson's disease was confirmed. I'll go to the marital history. So he has been married for more than 20 years, and he started having marital disharmony in the past 15 years. So the reason for this disharmony is, according to the history, he tends to push the responsibilities to the wife and blame her if something goes wrong. And he had this controlling behavior to the extent that he did not allow his wife to pursue masters as she wished. And so she decided to file for a divorce, and she herself started having depression due to the marital disharmony and the stress that she was going through, as she had to pay off the bank loan that wife mentioned that he tricked her into taking a bank loan, as he was blacklisted by the bank. So at that time, she was already planning to divorce him. Substance history is clear. There's no history of substance use. And I'll go to the pre-morbid personality. So here I'll have to explain a bit in detail. He has narcissistic personality traits. So he often believes that he is more superior, and he wants people to recognize him as such. And he feels his needs are more important than others, no matter what. And he has this preoccupation with how well he has been doing, and always in constant need of attention and admiration. So he often has this unreasonable expectation and expect others would cater to him, and he becomes furious when this doesn't happen. So this has caused a lot of problems and strange relationship with his children. Other than that, he can be quite oblivious and with lack of empathy and insensitive when when in interaction with others. And yeah, he was also characterized as being rigid and quite controlling. So this is his pre-morbid personality. Now I'll go to the mental state examination. I will point out the salient points here. So during our assessment in June 2022, rapport was quite difficult to be established as he appeared very guarded. He had very poor eye contact, and based on his general appearance, he appeared to have a stiff posture. Other than that, his mood was low, but his affect was was restricted. And at that time, he had persecutory delusion. And the physical examination revealed that upon walking, he had small and slow steps without swinging of the arms. He had a stooping posture and was not able to balance himself much. He had mask-like faces, and on bilateral upper limbs, he had tremors, cogwheel rigidity, and bradykinesia. Other than that, other examinations were unremarkable. His laboratory investigations were all normal. And we did a CT brain on the first admission, which was no significant abnormalities. And other objective findings, which is the depression inventory, anxiety inventory, both shows normal scores. MMSE and MOCA, as well as frontal assessment battery, was all normal. Okay. All right. So I will try. I'll try to formulate the case. Why, in regards to the psychosis that he's having. So the predisposing factors, probably why he's vulnerable to the current situation, can be due to his personality, which is the narcissistic traits. And why is he having this condition at this point of time? Probably the starting of dopamine minergic medication probably would have triggered this situation. Along with, it can be also because of the Parkinson's disease itself. And psychologically, it can be because of loss of functioning, where he actually there is a loss in his physical, there's some limitation in physical wise, like movement restricted, and he can't really do things that he wanted to do by himself. And there is some cognitive being affected as well. And social factors is ongoing marital disharmony, financial constraint, and caretaker distress can be precipitating the current situation. And what is stopping him from getting better, or what is pertaining this situation, can be continuation of the dopaminergic medication again, and we can point out towards the Parkinson's disease progression. And psychologically, we can say that the ongoing psychosis itself, it can prevent him from getting better. So there's delusion of infidelity and persecutory delusion, which makes him difficult to believe others, and that is stalling him from getting better. So, and things could be quite can be worse for him because he has been placed in a nursing home, which yes, definitely have some impact on him, on his recovery. So the current treatment for him is his anti-Parkinson's medication, which is Stalevo, 200 mg QID, and he's on quetiapine IR, which is an antipsychotic. Currently, he's on 225 mg online. So I'll just briefly tell everyone regarding the progress. So after the discharge from our ward, his care was transferred to the UMMC because of family's request, partly due to the logistic where he was staying. And we got to know that he was admitted once in UMMC, and neurological examination showed the Parkinson's symptoms. And based on psychiatric assessment, apart from irritability, he did not have psychotic symptoms at that time. So both antipsychotics and dopaminergic drugs were optimized, and he was given an appointment to see the psychogeriatrician and also the neurologist as outpatient. I have come to the end of my presentation, so I think I'll hand over the presentation to the next presenter, Prof. Azmin. Right. I'll stop sharing here, and Prof. Azmin, please, I'll give the baton to you. Thank you.
Good morning. Thank you, Dr. Situ, for the presentation, and thank you, Prof. Mahani, for the invitation and the very nice introduction. So my name is Sharul Azmin. I'm one of the lecturers from the Department of Medicine, Faculty of Medicine. And today I've been tasked to give sort of a précis of what Parkinson's disease is, like a simple introduction. So it'll be a very quick presentation, and consider, I'd like you all, the audience, to consider it as a sort of an appetizer, leading on to Dr. Hajar's main course, which is psychosis and Parkinson's disease. So this is my content. So epidemiology of Parkinson's disease, the prevalence worldwide is about 100 to 200 per 100,000 inhabitants. And then the yearly incidence is about 20 of 100,000 inhabitants. And the spread of Parkinson's disease is uniform, but it's not like multiple sclerosis, where you get an increased prevalence in more temperate climates. So Parkinson's disease is primarily a neurodegenerative disease affecting the elderly. So you can see in this graph, at age 54 years and below, the cases there's the cases of Parkinson's disease is about 5 cases per 100,000 inhabitants, but rises exponentially as you grow older. Now, because the global world population is aging, we expect that the prevalence of Parkinson's disease will also concurrently increase, and we expect a 2-fold increase by the year 2040, which is not long from now, 20 years from now. So what causes Parkinson's disease? So neuropathologically, we think that it has to do with these entities called Lewy bodies, which are deposited in the brain. Certain parts of the brain is more relevant in Parkinson's disease. So Lewy bodies are inclusion bodies made up of proteins called alpha-synuclein. So alpha-synuclein, we're not really sure what it causes, but we think it is involved in DNA repair. So in Parkinson's disease, Lewy bodies are deposited in many parts of the brain. But with regards to the motor symptoms of Parkinson's disease, the symptoms that you normally see, the relevant areas in the brain are the basal ganglia. And this is the 3D representation of the basal ganglia from the fMRI software from Oxford. And the basal ganglia are made up of many nuclei. And in particular, I'd like to draw your attention to this the substantia nigra, which is colored yellow. They're very small in the midbrain, the size of almonds. And this is a histological section of the substantia nigra. On the right, you see a section from a brain that has not had Parkinson's disease, and you see the melanin deposited in the substantia nigra. In contrast, in people with Parkinson's disease, because of the Lewy body deposition, the pigmentation is lost, and that's one of the pathologies that we see in Parkinson's disease. So this is a PET scan, a radiological technique. We can sort of show the dopamine uptake. So Parkinson's disease, because of the Lewy body deposition, it affects the dopamine uptake of the brain. You can see in a healthy control, there is quite substantial dopamine uptake in the basal ganglia. And you see in people with advanced Parkinson's disease, there is significant reduction in the dopamine uptake. And in the middle, it is a scan of a patient who has early Parkinson's disease, and this is typical. So, because people with Parkinson's disease, at the beginning, they present asymmetrically. So it's only one side that becomes damaged first. And then over the years, when the Parkinson's progresses, you'll get involvement of both sides of the basal ganglia. So when you get Lewy body deposition in the basal ganglia, you'll get all these what we call cardinal symptoms of Parkinson's disease due to dopamine deficiency. So you'll get classically what we call resting tremor. So tremor, it's very important to make a distinction. So the tremor in Parkinson's disease is classically occurs at rest. So when they eat or when they're using their arm to do certain activities, the tremor is not present. Then you have bradykinesia, which is slowness of movement, rigidity. So rigidity superimposed with the resting tremor will give rise to what people often call as cogwheel rigidity. And then at the advanced stages of Parkinson's disease, you get postural instability. So I told you that the Lewy body deposition in the substantia nigra basal ganglia give rise to the motor symptoms. But we now know that the process of neurodegeneration with regards to Lewy body deposition in the brain occurs much earlier than when the motor symptoms arises. So it starts actually, people say maybe 5 to 10 years before the manifestation of motor symptoms. Lewy body deposition already occurs in the brainstem, and then it rises rostrally through the midbrain, and then at this stage, this is called Braak stage 1 and 2, and then this is Braak stage 3 and 4, where you get all the motor symptoms. Now, the Lewy body deposition at Braak stage, this is a typo, Braak stage 5 and 6 affects the cortical, frontal lobes, limbic region, and this is probably when the neuropsychiatric manifestations starts to come to the surface. So this is another way of showing you the PD cause and symptoms of the Parkinson's disease cause and symptoms. So when motor symptoms develop, you get bradykinesia, rigidity, and tremor. And as the disease develops further, you start to get more non-motor symptoms such as psychosis, urinary symptoms, and then before that, you will have what we call premotor symptoms, just constipation. This is REM, sleep behavior disorder, and then you get loss of sense of smell and symptoms of depression. So, traditionally, when Parkinson's disease was in the 19th century, 20th century, it was thought to be a primarily dopaminergic neurodegenerative condition. And this is reflected by the medication that we use. We try to sort of supplement dopamine, or we give dopamine agonists. But over the past 2 decades, 3 decades, we now realize when we've noticed all these non-motor symptoms, and which do not respond very well with dopaminergic medication, we feel that there are other neurotransmitters involved, particularly serotonin, noradrenaline, and cholinergic medication. So this is a very good review article for those that are interested to read more on the topic by Paulo Boron, which is an authority of non-motor symptoms. And I've just taken a snapshot of one of the tables in his text, and these are the citations, the reference numbers in his text, and you can see that conditions like depression, there are papers there are several evidence that support dopaminergic, serotonergic, adrenergic, glutamatergic, GABAergic involvement. So just to summarize, so we've talked about motor symptoms, so non-motor symptoms, which is more varied, and you can class it in several ways. So in this diagram, we class it as neuropsychiatric problems, autonomic dysfunction, sleep disorders, ancestry, and others. I won't go, in the interest of time, I won't go and describe and try to describe all of them, but I'll just pick 1 or 2. So impulse control disorder is a condition where you get which was in our patient occurred where you get all these impulsive and compulsive behaviors, and sometimes that's part of the Parkinson's disease, but because of the involvement of the limbic region, but sometimes it's unmasked by dopaminergic medication, because dopamine, you mustn't forget, is involved in the reward system. So so impulse control disorder can be hypersexuality, compulsive shopping, pathological gambling. The other thing that I want to point out is REM sleep behavior disorder. So this is a phenomenon where when patients are sleeping and in REM sleep, so they are dreaming, so they act out their dreams. So so this is very significant, especially in the advanced Parkinson's disease, because they have problems with mobility anyway in the first instance, but because of this acting out their dreams, and can sometimes be violent, and then can cause injury to themselves or their sleeping partner. So do you have time? No, I'll just skip. We'll go back to this if we have time later on. So so I'm going to touch a bit about oral pharmacological therapy of Parkinson's disease. Like I said, because of the history of the development and knowledge that developed over the years, there is a strong emphasis of replacing dopamine. So, but that's starting to change now. So the cornerstone. And before I go further, I'd also like to point out that for Parkinson's disease, at the moment, there is no curative therapy. All the medications that are available are purely for symptomatic control. So people who've got Parkinson's disease, they have symptoms, we treat them, but the unrelenting progression of Lewy body deposition in the brain goes unhindered. So the cornerstone of oral pharmacological therapy, period is dopaminergic replacement. So there are several options. Levodopa, which is always given with an extra carboxylase inhibitor so that it doesn't get metabolized outside the brain. So this is drugs like Madopa or Cinemat. And we also have dopamine agonists. There are 2 or 3 dopamine agonists that is available in Malaysia. One thing to that I'd like to sort of mention is that dopamine agonist is notorious in unmasking impulse control disorders, which our patient has, and both dopamine, but more so dopamine agonist is also notorious in causing dopamine dysregulation syndrome because of the dopamine in the reward system. So maybe I should just to elaborate, dopamine dysregulation syndrome is a phenomenon caused by Parkinson medication, which leads to an addictive and excessive need for dopamine. So sometimes it's very difficult whether the patient is in dopamine dysregulation syndrome or whether they actually need medication because they're off. So the only way to know is for the physician to examine the patient, see to determine when they are asking for the dopamine replacement, whether they are actually off or whether they're actually on. So we've done that several times for the patient. So NMDA antagonists such as amantadine. So over time, because of the unrelenting nature of Parkinson's disease, you get sort of involuntary movements due to the dopamine replacement, what we call dyskinesia. So we give NMDA antagonists to try to suppress that, such as amantadine. So monoamine oxidase inhibitors and catechol or methyl transferase inhibitors are drugs that try to modulate the enzymes that are responsible for dopamine biosynthesis in the brain. So we try to inhibit this enzyme so that the dopamine in the brain lasts longer. So monoamine inhibitors example is selegiline, and then the COMT inhibitors and entacapone. So entacapone must be given together with levodopa. So that's the drug that you call Stalevo. All right, and then the anticholinergics such as trihexyphenidyl, benzaxol, and these are anticholinergic medication. So now we know that cholinergic deficiency occurs in Parkinson's disease, and it gives rise to neuropsychiatric manifestation as such as dementia. So sometimes, although in early Parkinson's disease we give anticholinergic medication, but over time it is very, very common for us having to stop this medication because it causes more harm than good. So just to reiterate, so pharmacotherapy for Parkinson's disease, we've already talked about oral pharmacotherapy for Parkinson's disease, which is oral medication. But as the Parkinson's disease progresses, the gastrointestinal system absorption of drugs becomes impaired. So you've got to find other ways to try to deliver these dopaminergic medications. So we have several options. We've got 2 options in Malaysia, 3 options in Malaysia. One is by giving the dopaminergic medication via a skin patch. So we stick the patch on the skin and it gets absorbed subcutaneously. One is by giving the drug in a subcutaneous form. The other is performing deep brain stimulation surgery. And finally, we give levodopa in a gel form, but via percutaneous endoscopic jejunostomy tube, a patch tube, so directly to the jejunum. All right, but this is not available in Malaysia. So this is the duodopa that I mentioned in the previous slide. So it's in levodopa intestinal gel. So you've got, the patient has to undergo a procedure to insert the patch tube, and then you can deliver the levodopa gel continuously via pump. This is the skin patch. Rotigotine is a dopamine agonist. And so you stick it in on your skin and leave it for 24 hours. And the patch is impregnated with rotigotine. It diffuses through the skin into the systemic circulation. And apomorphine is another dopamine agonist. Now, apomorphine has a very, very short half-life. So that's why we have to give it subcutaneously via pump. And finally, this is deep brain stimulation surgery. So another way of trying to alleviate. So all these medications are very good to relieve motor symptoms. So the deep brain stimulation, what it does is, what we do is we insert an electrode into the brain, and this electrical stimulation helps in alleviating the motor symptoms of Parkinson's disease. Now, this is a about 15-year-old study. One of the problems with deep brain stimulation surgery is, I think we've already touched about drawbacks of certain medications with regards to neuropsychiatric manifestation. But deep brain stimulation surgery, I just want to touch, it has an increased association with depression and suicide. So patients with significant symptoms of depression, major depressive disorders, they are contraindicated at the present moment to undergo deep brain stimulation surgery. And this is sort of this is reaffirmed by a more recent meta-analysis published in 2020 by Chinese researchers. So to conclude, I hope by now you'll I'm able to relay the certain points, namely that Parkinson's disease include motor or non-motor symptoms. And then and in Parkinson's disease, it's not just about dopamine, it's about other neurotransmitters also. And sometimes that's more difficult to treat. The treatment at the moment for Parkinson's disease is symptomatic and not curative. And treatment and the treatment of Parkinson's disease is very challenging, especially in patients who have a multitude of motor and non-motor symptoms and advanced Parkinson's disease. With that, I end my presentation. Thank you.
Thank you very much, Prof. Azmin. So while Dr. Hajar is sharing screen, we are running quite out of time, but I think I asked Cik Buhari just now that we get extra time lah for the CPC. So probably we'll finish by 9:10 or 9:15. Go ahead, Dr. Hajar.
Assalamualaikum warahmatullahi wabarakatuh. Can you hear me clearly? Boleh? Boleh dengar?
Yeah.
Yes.
Okay. Assalamualaikum. Thank you, Prof. Mahani, for the introduction, and thank you, Dr. Setu and Prof. Azmin for the fantastic presentation. I know we don't have a lot of time today, so I'm just going to go through quite quickly. I hope you can see my slide. Okay, so these are the today's topic is on the Parkinson's disease psychosis, and we are focusing more on the dopamine neurotransmitters. So these are the subtopic that I'm going to cover today. I was advised by my colleague Prof. Nick to start with the key take-home message and then end it with the same key take-home message. So I hope if you decided to doze off it for the next few minutes, just remember these 4 points. Number one, if you're treating patients with Parkinson's disease, please do assess for psychotic symptoms as well. And number two, Parkinson's disease psychosis can be due to intrinsic and extrinsic factors. Number three, multidisciplinary team approach is very important in the management of Parkinson's disease psychosis. And the last one is a careful balance between the dopaminergic medication and antipsychotic medication is very important in the management of Parkinson's disease psychosis. So these are the key take-home message. Let me just start with the presentation. Psychosis in Parkinson's disease. What is psychosis? Psychosis is a condition that causes someone to lose touch with reality. And most of the time, patients will present with hallucination, which is a perceptual disturbance, and also delusion, which is a fixed and false belief. So what happens in Parkinson's disease psychosis? This is a rating scale that I've seen by the Movement Disorder Society. It's called the MDS-UPDRS scale, Movement Disorder Society United Parkinson's Disease Rating Scale. So this rating scale actually shows the different symptoms or psychotic symptoms that patients with Parkinson's disease might experience, from minor illusion, which is a rating of 1, to hallucination with insight, which is a rating of 2, hallucination without insight 3, and the last one, delusion, of 4. This is actually looking at this scale, it shows that the symptoms actually evolve and it's a continuum of symptoms. And the last one would be delusion. But this is a bit different from what we see, what psychiatrists see in primary psychosis, for example, schizophrenia, where you see, symptoms as separate and not as a continuum, and does not show any sign of prognosis. But in Parkinson's disease, apparently it's different. So what is illusion? Illusion is a misinterpretation of a normal, of a real stimuli, and this can happen to anybody, to a normal person, but it happens more in patients with Parkinson's disease. So the most common type is kinetopsia. About 1 in 4 of patients with Parkinson's disease do experience this, which is basically they perceive something as moving when actually the object is stationary. And the second most common is object misidentification, which means a person perceives something as a different thing. For example, a coat rack might be misperceived as a person, or a shadow outside a window might be perceived as a monster, for example. Hallucination can also happen in Parkinson's disease. It happens about 50% of patients over the course of the disease, and about cross-sectionally, if you interview patients with Parkinson's disease, about 25 to 40% of them do experience hallucination. And most commonly, the hallucinations are visual and in the form of non-threatening people. Sometimes they can see like small children or small animals, cats and dogs, which are not really that scary. What is unique in Parkinson's disease psychosis is these 2 hallucination. One is passage hallucination, which is a sense that they can see that a motion of an object at the periphery of the visual field, but when they confront it in the frontal vision, is the thing is not there. So for example, they're talking to you, but they can see like a cat moving at the periphery of their vision, but actually there's nothing there. The second one is presence hallucination, which is a feeling or an idea that somebody is close by in the same room, for example, or somebody who has passed away in the same room as the patient. So this is quite unique in Parkinson's disease that we don't normally see in primary psychosis. So these are the collection of studies that was done. And Abdul Rahman et al. Published in 2004 is our own study that was done in UKM. And I think my colleague, Prof. Suryati, is one of the co-authors, basically studying patients with Parkinson's disease and having hallucinations. So the prevalence is about 13% locally and going up to 40% in the France. And basically looking at the risk factors of hallucination in Parkinson's disease, cognitive problem has been shown to be significant association with hallucination. The duration of the Parkinson's disease and the age, it depends. Some studies did not see any significance, but what is important is the dosage of the levodopa. Actually, all studies did not see any significant association. So basically, the absolute dose of the levodopa does not really associate with having hallucination. So probably there is something else that is happening, but maybe something in the brain intrinsically that is causing the hallucination, which I will talk about in a while. And delusion is a fixed and false belief. Delusion happens about 3 to 30% of patients with Parkinson's disease, and generally in the form of paranoid in nature, which is what is experiencing by our patient, Mr. Z, just now. He had a persecutory delusion that people are trying to harm him. On top of that, a common delusion is spousal infidelity, which is also what is experiencing by our patients as well. Other delusional themes are they believe that they're being abandoned by their family members or other people living in their house, or people planning to harm them, people stealing their money, or purposely misplacing items, and or people spying on them. So these are quite common in patients with Parkinson's disease psychosis. So let's talk about the diagnosis and in our patient. So as what Dr. Setu mentioned, this is quite a complicated case, and there are so many moving things that is happening in this patient. There's a lot of symptoms. Looking back at the patient's clinical presentation, number one, first it started with an onset of Parkinson's disease. I would say it's an early onset, but I think Prof. Azmin can correct me if I'm wrong. And then he developed depression and anxiety afterwards. And then only he started to develop psychosis. On top of that, there's also an ongoing narcissistic personality traits that is also perpetuating the disease burden. So this is just a diagram showing the interaction between different areas of the brain and also, the caudate nucleus, the thalamus, the globus pallidus, and the different system in the brain, and the sensory-motor system, the frontal system, and the limbic system. So it shows that, just looking at the diagram is so complex and interconnected, and it makes sense why people with Parkinson's disease do also develop other symptoms and non-motor symptoms, cognitive problems, and also emotional and psychosis as well. So back to our patients, Mr. Z. What is actually the diagnosis? I think most of you have already start thinking of what is the diagnosis in this patient. To be honest, we are not really sure as well. But the first two diagnoses that I'm showing here is probably what is happening. This is according to the DSM-5 criteria. The first one is psychosis due to medication, which is the dopaminergic medication that the patient was on. I think Dr. Setu has already presented how the timeline when there's increase in dopaminergic medication, that the psychotic symptoms started to develop. So the points for that is the patient actually fulfilled the DSM-5 criteria, and also the timeline as well, which the symptoms started after initiation of the dopaminergic drug. The second one is psychosis due to medical condition, which is the Parkinson's disease. So this is the question, what is actually causing the psychosis? Is it internally? Is it something that is due to the Parkinson's itself, or is it the medication? However, if you look at the DSM-5 criteria, the first diagnosis will be a better option, because of the starting of the medication before the start of the psychotic symptoms. We've talked about impulse control disorders. Thank you, Prof. Azmin, for explaining that. And this patient did have a hypersexuality. And we were also thinking of dopamine dysregulation syndrome. And the points for that is there's this period of time where the patient actually increased the use of the dopaminergic drug, even when the patient was in the off period. And there's also hypersexuality as well. However, towards the end of the presentation, we did not see this excessive use of the dopaminergic drug, and that probably is also due to the ongoing persecutory delusion that this patient is having, because the patient actually believed that people are trying to drug him using the medication. So in the end, he did not actually, excessively took the dopaminergic drug. And of course, primary psychosis, schizophrenia should be one of the diagnoses that to consider. However, according to the DSM-5 criteria, although patient had psychotic symptoms, hallucination and delusion, the criteria E, which is a disturbance is not attributable to medical condition, we can't rule that out. So hence we take the first two diagnoses here. And from now on, I would just term it as Parkinson's disease psychosis to make it easier. So this is just a diagram showing the possible triggers of psychosis in Parkinson's disease. We've talked about the PD medication, and also there's a possibility of direct brain neurodegeneration from the Parkinson's disease itself. We also need to think of whether there's any comorbid psychiatric disease, whether there's any dementia of Lewy body, for example, that is actually happening in this patient. And a non-Parkinson's disease medication, whether this patient is also taking other medication that can precipitate psychosis, and whether there's any acute infection or other illnesses that can cause psychosis, which may be in the form of a delirium that is happening. So these are the things that we need to think of when we manage patients with psychosis. So this is just a diagram showing the interaction between Parkinson's disease and psychosis, and how does it affect the disease burden. As we know, in terms of neurotransmitters, we're focusing on dopamine for the sake of this presentation. The reduction in dopamine level in the substantia nigra causes Parkinson's disease, and increase in dopamine level in the mesolimbic pathway does cause psychosis. Parkinson's disease can lead to psychosis due to medication or something intrinsic happening in the brain. Antipsychotic that is being used for psychosis can also cause Parkinsonian symptoms and worsen the motor symptoms. And Parkinson's disease and psychosis can lead to an increase in disease burden, which perpetuated by his narcissistic personality traits, and also the marital issues and the other social issues that this patient is having. Let's talk about the connection between Parkinson's disease and psychosis. We talked about intrinsic and extrinsic factor. Specifically for the intrinsic factor, if you want to look at what is happening in the brain, we should look at the brain, whether there's any changes in the structure of the brain. So a study have done to look at structural imaging on patients with Parkinson's disease with visual hallucination. There's actually atrophy in the primary visual cortex, the visual association cortex, the limbic region, and the cholinergic structures, which is what you would expect when patient is having visual hallucination and also delusion. How about the function of the brain? If we look at the functional imaging, there's also changes in the dorsal and ventral visual pathways in the brain, which I'll explain a bit more in this slide. If you can see, this is a study looking at patients with Parkinson's disease, comparing between patients who are hallucinating and patients who does not experience hallucination. If you look at the bright yellow color here, patients who were not experiencing hallucination, they do have, when they are being stimulated by a light, for example, in this study, there's an increase in activity at the posterior brain, which is the temporal lobe, and where you would see in a normal person. However, in a patient experiencing hallucination, the increase in activity is at the anterior of the brain and the front of the brain. So in patients with experiencing hallucination, the visual information projects anteriorly, and there's poor processing in the posterior region and marked activation in the superior frontal gyrus. So that is not something we would see in a normal person. Looking at the patient specifically, this is just a report of a patient, a 66-year-old patient with a 4 years history of Parkinson's disease, actively experiencing hallucination. So the functional MRI showed that the blue signal here is a decrease in cortical activity in the occipital region, and there's an increase in cortical activity in the middle frontal lobe, the cingulate cortex, and the insular cortex, and the thalamus. So this is, normally we will see an increase in cortical activity at the back of the brain instead of a decrease in this patient. So it shows that something intrinsic is actually happening and causing the psychosis in patients with Parkinson's disease. But how about extrinsic factor, which is medication related? As we know, treating patients with Parkinson's disease is to increase the dopamine level in the substantia nigra. However, this also causes an increase in dopamine level elsewhere in the brain as well, and hence causing the psychotic symptoms. This is a diagram that I think students should know, especially undergraduate students. Maybe you would be asked this question in your exam. So we do have 4 dopamine pathways: the mesocortical pathways, the nigrostriatal pathways, mesolimbic pathway, and tuberoinfundibular pathways. So this is just a diagram showing the differences. I think the Prof. Azmina already mentioned about this earlier, the difference between the substantia nigra between Parkinson's disease patient and healthy patients and patients with Parkinson's disease. Basically, I just want to show that Parkinson's disease do not just affect the nigrostriatal pathway, but also the other dopamine pathways as well. So another theory of how medication is causing psychosis is the hypersensitization of the dopamine receptors in the nigrostriatal pathways after chronic stimulation from the medication. And this hypersensitization then hence cause dysfunction of the limbic structure responsible for assigning emotional and hedonic significance to the sensory input, and hence causing misattribution of internal stimuli originated from the external sensory world. And that is why patients started to develop illusion and hallucination and so on. So how about psychosis causing Parkinson's disease? Is mainly drug-induced. As we know, positive symptoms, hallucination and delusion is caused by increase in dopamine level in the mesolimbic pathway. And when you start antipsychotic, that is actually aimed to reduce the dopamine neurotransmission in the mesolimbic pathway. However, that causes the effect to the nigrostriatal pathway, and hence causing the Parkinsonian symptoms as well. So back to Mr. Z's case, this patient also, on top of the Parkinson's disease, the motor symptoms and the psychotic symptoms, he also has ongoing narcissistic personality traits, where he had inflated self-importance, need for admiration and lack of empathy, and that is affecting his relationship with his wife and his family. And now, they are slowly, not there for his support. And that both of this increases the disease burden in this patient. And because of the Parkinson's disease, he's not able to work. Now he requires a lot of assistance in his daily activity, and now he's staying in a nursing home. And the ongoing persecutory delusion against the caregiver in the nursing home, that hence more perpetuating the problems that he's having. So what are the management for Parkinson's disease psychosis? The most important thing is teamwork. And this, I'm really appreciative of the neurology team. I think the past few admissions that this patient was admitted to the psychiatric ward, we do have very close discussion and close relationship with the neurology team, and we really appreciate that. So we need to work as a team, the neurologist, the psychiatrist, psychologists, OT, physiotherapists, nurses, and the caregiver. This should done together as a team. And the treatment approach, it should be first, we need to rule out any other medical condition, like I mentioned earlier, whether there's any infection going on, or whether there's any brain pathology actually causing the psychosis presentation. Number two, check the medication. Is the patient on high dose of dopaminergic medication? Is the patient self-prescribing or taking more medication than he was prescribed? Or is there any other medication that is also causing psychosis? And then non-pharmacological approach. Then the last one, pharmacological approach. Let's talk about non-pharmacological approach. The first thing is it should be centered to patient-centered care. The first thing that you can do very easily is changing the environment, because as we mentioned, illusion happens when there's the lack of stimulus. For example, when the patient is in the very dim room, there's not a lot of lighting, then they can misperceive certain stimulus to become something else and can be scary to them. So by improving the lighting, changing the light bulbs, or removing things that can be easily misinterpreted, for example, the coat rack, or things on the floor, for example, that itself can already improve the problems with illusion. Behavioral management, by giving them reward system, rewarding good behavior, that has been also effective. Family intervention is very important, and that requires a lot of work for this patient. First, psychoeducation to the family members and the patient, giving the family support as well, and also teaching them, what to do in terms of crisis management. Of course, validation therapy is very also important in this patient. It can be very scary, having a lot of this belief that people are trying to harm you, and seeing things that are not there. So by giving them a lot of validation and reassurance, that can also reduce the agitation and the aggression in this patient. At this point of time, there's no guideline for non-pharmacological approach for Parkinson's disease psychosis. However, this is taken from the guidelines from neurocognitive disorders and also psychosis. Then medication. So this should be the last option, because we don't want the patient to be on so many different medications that can interact with each other. Of course, a patient is experiencing psychosis, antipsychotic will be the option. However, there's also other medication that has been shown to be effective in case reports, but big studies have not done to prove this. Rivastigmine has been shown to be effective. Antidepressant and memantine has been shown to be effective in psychosis, and especially in patients with Lewy body dementia. So how about antipsychotics? Yeah, we do give antipsychotics. However, this is very important to have a very good balance between the antipsychotic and the Parkinson's disease medication. We don't want to worsen the motor symptoms by giving antipsychotics, and at the same time, giving too much Parkinson's disease medication can also worsen the psychosis as well. So this is not easy, but it can be done through collaborative approach with the neurologist. So what are the antipsychotics that can be given for Parkinson's disease psychosis? Actually, clozapine is a very good medication to improve the psychosis. However, we psychiatrists are very used to give clozapine, but this is mainly reserved for treatment-resistant schizophrenia or difficult to treat schizophrenia because of the risk of neutropenia and agranulocytosis. And patient require multiple blood tests and weekly blood tests. But a spoiler alert, I will talk about the dosage in a while. Actually, Parkinson's disease psychosis, you only need a very low dose of clozapine for the psychosis. Quetiapine, this is the medication that we gave for this patient, has been shown to be effective. However, lack of evidence of efficacy actually, but it causes a sedation, which is actually good for patients with Parkinson's disease, because we know that sleep is very important in and it has a link with psychosis as well in Parkinson's disease patients. The third medication is pimavanserin. This is not something that we are used to give in Malaysia. It's not available in Malaysia actually. But what is unique is that it is an antipsychotic that has an inverse agonist at the 5-HT2A receptor without any D2 dopamine antagonist property. It does not touch the dopamine receptor. So hence it will be good for patients with Parkinson's disease. And actually in the US, this is the only licensed medication for Parkinson's disease psychosis. From what I read, it's quite expensive in the US as well. So I'm not sure whether it's going to be available in Malaysia or in UKM, but we hope that it will be available. So this is just a diagram showing different studies looking at the effectiveness of clozapine for Parkinson's disease psychosis. They did RCTs.
So Taja, can you conclude your talk?
Okay. So basically, this slide just shows that you just need very low dose of clozapine for patients with Parkinson's disease. This is compared to when we treat treatment-resistant schizophrenia, that we can give about 400 to 600 milligram per day, but in PDP is only about less than 50 milligram. So pimavanserin is not available in Malaysia, but this is a phase 3 trial showing the improvement in positive symptoms of psychosis, and also its change in CGI improvement score. So I think I will skip these two slides. So back to the key take-home message. Please do assess for psychotic symptoms in patients with Parkinson's disease. Parkinson's disease psychosis can caused by intrinsic factors and extrinsic factors. A multidisciplinary team approach is very important, and a very careful balance between the dopaminergic medication and antipsychotic medication is important. Thank you very much. I'm so sorry for extending the time, Prof.
All right, thank you.
Thank you.
Yeah. Thank you very much to all the speakers. There are some questions going on in the Q&A section, but unfortunately we are running behind time, so I don't want to be delaying you from your other task for today. Probably I'll just take the opportunity to thank again all the three speakers, Dr. Setu, Prof. Azmin, and also Dr. Hajar, for a very good presentations. This is such a complex topic. You all have delivered the topic in a very easy to understand manner and quite capturing to the brain as well. So thank you very much. And yeah, so we will end our CPC today now. Thank you again, and have a good day, everybody. Assalamualaikum.
Thank you all. Have a good day.
Terima kasih Prof. Sila scan
Terima kasih.
untuk CPD pun. Lepas ni kita ada quizzes quizzes untuk undergraduate. Okey, mohon gunakan nombor metrik untuk undergraduate. Untuk undergraduate nombor metrik. Untuk undergraduate mohon gunakan nombor Okey, terima kasih semua. Terima kasih Dr. Hajar. Saya end dulu. Terima kasih.
Terima kasih. Saya dah jawab soalan yang ada ya. Terima kasih.
Quiz tu untuk undergraduate sebenarnya, Doktor.
Soalan Q&A tu.
Okey, terima kasih.
Okey.